Hello, everyone entering the meeting room. For those I haven't met, my name is Ashley Biggs. I am the Marketing and Outreach Librarian for the Maryland State Library for the Blind and Print Disabled. Welcome to our LBPD Live program. I'm so excited to have you here. If you are new to LBPD, we provide accessible reading options to those unable to access traditional print. So you may find in your world that there's someone out there who does not have the ability to access print due to visual, physical, or organic print disabilities. And our library tries to help our patrons continue the love of reading. And we are very blessed that we get to do programs and events across the state, just like today. People are still coming in. And so, if you miss anything, don't worry. The program is being recorded and will be made available on our YouTube channel. Now, for tonight's program, a couple of quick housekeeping rules. Again, this program is being recorded. If you don't wish to be recorded, you do not speak when it comes time for questions and answers. If you would like to submit a question anonymously, you can send me a private chat, and I'll be happy to share that question privately with our presenter. And of course, I would like to thank the sponsor of tonight's program, Insight Memory Care. Insight Memory Care, first and foremost, Melissa, who is here tonight, and I'm going to go over her biography in just a second. Insight Memory Care is a nonprofit providing quality and memory and cognitive care for families living with dementia. They do this through specialized day programs for individuals living with memory and cognitive impairments, support for care partners and families, and education and engagement opportunities for the wider community. Insight offers a spectrum of holistic care with a vision of a community where those living with cognitive impairment can achieve the highest quality of life. And if you have not had a chance to visit their website, if this is the first you're hearing about it, it is www.insightmcc.org. And again, that's www.insightmcc.org. And I would like to introduce our speaker tonight, Melissa Long. Melissa is a graduate of the University of Southern Maine with a bachelor's in therapeutic recreation and leisure studies. She is a certified recreational therapist and a dementia care specialist with over 20 years of experience for supporting older adults. She has received multiple accolades, including the ATRA Frank L. Basile Clinician of the Year. That was in 2016. And the 2024 Pride of Our Community Leader Award. And she has presented at conferences and published evidence-based programming with experience of living in Romania to support orphans and serving as a social coordinator for the CP-ISRA World Championship. Melissa brings innovative, community-focused care to both clients and caregivers. And I just can't say thank you enough for answering my call when I posted it out there on LinkedIn and said, hey, I'm interested in this. Anybody got anything? And she was like, me, I got it. So thank you, Melissa, for being here.
Absolutely. Thank you for having me. This is such a pleasure and an honor to do this program. And so Ashley asked me to come talk about Dementia 101. And so that's what I'm going to do today. So let's get started. Interesting. It's not, my PowerPoint is not moving. Sorry. Hold on. Nope, there it went. It's moving really slow. Let's try that again. All right. So she already did a lovely introduction. I'll just add that Insight, we are in our 41st year this year. We started in a church when some caregivers said, we take care of our person with dementia all day long. Is someone going to take care of us? And that's where Insight came from, realizing that it wasn't just the person with the diagnosis, but the caregiver needed support as well. And so that's what's led us to having that care, connection, and creativity. True or false? Is dementia a normal part of aging? It is not. So what is normal aging? It's walking into a room and forgetting what you went there for, but remembering a few moments later. I do it all the time. Losing things from time to time, but backtracking and finding them. We forget about an appointment, but remembering later, making a bad decision once in a while, and other mild forgetfulness that doesn't significantly affect our day-to-day life. We are all humans. We're not robots. We're not going to be perfect. And as we age, our brain does shrink, and that's not really dementia. That's just normal aging. And so things are going to change. You know, we might have been able to do 5 things at once before, but as we age, we can only probably do 2 or 3. So we have to adjust to that as we age and know that that's okay. If we're looking at warning signs that might tell you that you have dementia, we're looking at memory loss that disrupts your daily life. So that means you can't do things. You can't balance your checkbook. You can't remember appointments to go to them. There could be challenges planning or solving problems, difficulty completing familiar tasks, confusion with time or place, trouble with visual images and spatial relationships, new problems with words and speaking or writing, misplacing things and losing the ability to retrace our steps, decreased and poor judgments, leaving that front door unlocked or the stove on, withdrawal from work and social activities. This is one when families start to notice the change because people stop going to social things, whether it's church or a club they used to be a part of, because it's too hard to follow conversations. It's too hard to remember names. And changes in mood and personality. So we have a diagnosis called mild cognitive impairment. This causes more memory problems than normal compared to others in the same age group, but it does not significantly interfere with your ability to participate in daily activities. You can still drive, and still do all the things. It's not a type of dementia, but it increases your risk of developing Alzheimer's or other dementias. So mild cognitive impairment is the diagnosis that you may have before dementia. And it is, anyone can have it at any age. I'm in my 40s and I know I've got it because I don't sleep well. And so anyone can have it. But what's nice is that there's things from it you can fix. You can have mild cognitive impairment because you have a low vitamin level in B6, 12, or vitamin D. It could be because you have anxiety or depression. Those things we can fix. And the most important thing to remember is if you do get this diagnosis of mild cognitive impairment, I want you to say, from what, doctor? Why do I have it? And that's the most important question you can ask, because if they can tell you, yes, it's because of Alzheimer's, but you're not into the dementia phase yet, you know what's coming. But if they say it's because your vitamin B6 is low, we can take vitamins or get injections to fix that. And that's something that's fixable. Only about 10 to 15% of people that have this diagnosis of mild cognitive impairment actually get dementia. So I don't want you to be afraid of this diagnosis. I'd rather you find out about it early enough so that there can be changes made and things that we can fix so they don't end up becoming a permanent thing. Okay? Oh, my internet is moving slow again. I apologize. There it goes. So the first dementia I want to talk, dementia I want to talk about is it's not a normal part of aging. Dementia describes a group of symptoms affecting your thinking, your language, and your social abilities, severely enough that it takes away from your daily functioning ability. Dementia is not a specific disease. I have lots of people ask me, does someone with Alzheimer's have dementia? Alzheimer's is a dementia. So when we look at an umbrella, the top of the umbrella says dementia, but then hanging off all the spokes on strings, are all the different types of dementia. And there's close to 170 types of dementia. And we have some dementias that are irreversible, that are hanging off those threads from the umbrella, and some that are reversible. So when we look at reversible ones, it might be because of an infection like pneumonia or a urinary tract infection. It could be because you have depression or a brain tumor. You could have a metabolic disorder. It could be because of medications you got put on. Or it could be that vitamin deficiency we talked about. Those things are fixable. Those are those reversible dementias. So they can potentially go away. Then we have those irreversible dementias hanging down from that umbrella. And that's Alzheimer's disease, vascular dementia, dementia with Lewy bodies, frontotemporal degeneration, and Parkinson's dementia with many, many more. And we're going to go into some of these in detail just a little bit. So let's look at the first one, Alzheimer's disease. We cannot reverse Alzheimer's disease. We cannot fix it with a diet or pills. It's progressive disorder that causes problems with memory, thinking, and behavior. And it accounts for about 60% of people having dementia cases. 6.7 million Americans have Alzheimer's disease. Most are over 65. However, about 200 to 600,000 have early onset Alzheimer's. So you can have it in your 30s. There's no way to stop we can slow the disease a little bit. However, we can treat the symptoms. So we have 2 new infusions. I won't go into depth with those. You can go on our website and there's some great webinars that talk about them more in depth. You can get an infusion. There's one that's once a month and one that's every 2 weeks. That can slow the process down for about 9 months to 12, depending on which one and how your body reacts. But mostly what we do when someone has this diagnosis is we meet them where they're at and we treat the symptoms. So that might be anxiety and depression, eating habits, things like that we can do. Next one we see is vascular dementia or vascular cognitive impairment. And this occurs because of brain injuries such as microscopic bleeds and blood vessel blockages. The location, number, and size of the brain injury actually determines how the person's thinking and physical function are affected. And so this is a diagnosis that I actually can't give any preemptive symptoms to the family because it depends on where the damage is for what symptoms they're going to have. Okay. If they have it like my grandmother did, she had it in the frontal lobe area, so very much a behavioral variant, and she became very angry. So it really depends on where the strokes might have been or the vessel blockage is. You might have had a TIA, so a mini stroke. It could be because of diabetes. So all these things can affect that. So this is one that we can try to prevent by having good health, such as eating well, exercising, taking care of hypertension and diabetes, and high cholesterol. So those are all things we can actually do to help with this one. And this is one of those dementias that progresses in steps. Think of a set of stairs in your house, and it's flat, and then it drops down, and then it's flat, and then it drops down. And so that's how the symptoms react. So it's pretty stable for a while, and then they decline a little bit, and then it's stable for a while, and then they go decline a little bit, and then it's stable again. And so that's how their symptoms progress with this dementia. Next, we have Lewy body dementia. This is the one that Robin Williams was diagnosed with. It's an umbrella term for dementia with Lewy bodies and Parkinson's disease dementia. The first signs usually of someone having dementia with Lewy body is often deficits in their attention and their executive function. So that executive function is balancing the checkbook, problem solving, working at a job, driving a car, all those things. Other symptoms we might see include fluctuating cognition, or recurrent complex visual hallucinations, whether they're good hallucinations or bad ones, and spontaneous features of Parkinsonism. So when I say Parkinsonism, people walk with their toes, they have tremors. So we'll see some of those. But what's really important in this definition of what Lewy body is that fluctuating cognition. So a lot of people with Lewy body, it's like a roller coaster when we describe it. So they have moments, and it can be all the way till the end, that they are lucid and can have a perfectly good conversation with their spouse. But other moments, they might say to them, hold on a second, Louie's here. They like to name it. And then when it's gone, okay, Louis gone, we can get back to what we're doing because they're having hallucinations in those moments. They're getting disengaged because of what they're seeing. And so, but they come back. And so their short-term memory lasts quite a bit longer when they have Lewy body versus other dementias. Then we have the frontotemporal degeneration. This is what Bruce Willis was diagnosed with. It's a disease process that results in progressive damage to the temporal and or frontal lobes of our brain. It causes a group of brain disorders that share many clinical features. So one of them, there's a behavioral variant, someone who's very upset and agitated. And there's also primary progressive aphasia. And that's what we first heard with Bruce Willis. What that means is the words he's thinking up in his brain aren't coming out through his lips. And so they have a hard time taking the words from up in their brain and being able to express them. And so then they have gradual progressive decline. So theirs is more like a steep slope when you're skiing. And there's a lot of behavior and language issues with this one. And it usually is a younger onset in the 50s and 60s. So a lot of people find out they have this because they're messing up at work and having difficulties. One thing with frontotemporal lobe, a lot of times people with it have anagnosia, which is the unawareness of the disease. So they'll say, I just forget names here and there, and we'll have a full-blown conversation and they seem fine, but it's that executive function, that background stuff that makes them have the ability to be independent that they can't do. And they can't recognize that they're having that deficit. Their brain doesn't allow them. So sometimes you may not know someone has dementia, but just by them having a conversation if they don't have the primary progressive aphasia. Some other types of dementia, Huntington's disease has dementia as it progresses. Creutzfeldt-Jacobs disease, this one is the genetic version of mad cow disease. This one progresses very, very quickly. Wernicke-Korsakoff syndrome, this one is an alcohol-induced dementia. Then we have normal pressure hypocephalus. We have HIV-associated dementia, MS-associated dementia, and chronic traumatic encephalopathy, so CTE. And we hear a lot about that with athletes and veterans. So we see quite a bit of that in the DMV area. Then we have mixed dementias. Did you know you could have more than one? You can. The most common mix we see is Alzheimer's disease, and then they live long enough with it that they then get vascular dementia. But there can be other combinations. So, for instance, I know someone who went in, had all their scans done, and when they were looking at the MRIs, they went, oh, yep, you have Lewy body dementia because all the parts in your brain for Alzheimer's look great. And then they went to do all the other tests and they did a spinal tap. And when they pulled the fluid out, it read that he had Alzheimer's. So he had both Alzheimer's and Lewy body. So it is possible to have two. Recent research suggests a large portion of people over age 80 can have the mixed dementias. And the symptoms and abnormalities in more than one type of dementia are happening simultaneously. So say you have vascular and it's in that frontal lobe, but you also have Alzheimer's, you could start having that behavioral variant with the agitation and paranoia. So, we have to work symptoms with multiple things going on. So when we look at dementia at Insight, we really like to look at it kind of in three parts. So we have the early to mild stage, and that's where memory loss of recent events, getting lost or misplacing objects, and difficulty with complex tasks or situations. These people can still take a shower on their own for the most part, look in the pill box, take their meds, just might need some cueing to remember doctor's appointments, that it's lunchtime. When we get to that middle and moderate stage, there's an increased confusion. There's poor judgment. That's when the stove gets left on, the door gets unlocked. There's communication challenges. So they might be answering yes, but meaning no. They'll need assistance with tasks like dressing and grooming, and not physical help, but more of the verbal cues of, okay, now you need to put your shirt on. It's time to brush your teeth, putting things on the counter in order of what you would use to brush your teeth to cue them. And then we have that last stage, that late to severe stage. And this is where you lose that ability to communicate, loss of physical capabilities, and need for full-time care. People in this stage should not be home alone. They should have support, and whatever that might look like, from bringing contract care in or having family take care of them. When something is happening that's not normal for a poor person, we need to let people know. And that doesn't mean that they're bad things. It could be good things too. Mrs. Smith sees a kitty cat in the corner and it's eating the food on the plate. People are like, oh, that's so cute. That's still a hallucination, and we need to share it with the doctor. And so it's really important that we share a piece. Or the fact that John keeps going to the store and buying gardening gloves, and I realized we have 60 pairs in the garage. Well, that's because he can't remember where he put them, and it's easier just to go buy another pair. So these things are important to share. It's not saying you're not taking care of them. It's not saying that something is horribly wrong, but it means there's some change, and it might be a change that we can make better if it's caught early enough. So it's really important not to keep these things quiet and to share everything with the doctor. Dementia is diagnosed through a complete medical assessment, which may include seeing a neurologist. And so, you'll get blood work, they'll do an MRI, potentially a PET scan, a spinal tap. For Lewy body, they do a skin biopsy. But they also are doing a med check. They're doing a family history. They want to talk to all the family members and people around them to really get in-depth knowledge of how the person acts throughout the day and what they do. And so those are all important, but you may also be told, we want you to do a full neurocognitive workup. So that's not coming to me and having a MOCA screen done that takes 20 minutes. It's you go in for 3 to 5 hours and do a full-blown, with a neuropsychiatrist, a test done to see where all the pieces in your brain, and it can actually pinpoint about 90% of what dementia you have, which can allow us to make sure you're on correct meds for certain symptoms, be prepared for certain symptoms that might happen, and so forth. There are treatments available to help with symptoms. So there's some common medicines that they've used with Alzheimer's, like Aricept and Namenda, that can help slow down the process. There's behavior meds that can help with anxiety and depression, because about 62% of people with dementia do have a diagnosis of depression. So we deal with those. We help with sleep patterns and eating habits if need be. So there are things out to help with those pieces. So some of these changes you're going to see with dementia is progressive memory loss. And this is a slow process. So if you see a really drastic change in memory very quickly, good chance it's delirium, and that is caused from an infection. And that is a fixable dementia. That's one of those hanging off the umbrella that's fixable. And so you may have a urinary tract infection causing that, or pneumonia. And so those things you want to get into the doctor right away. That's not a long-term diagnosis. This is something we need to figure out right away and treat whatever's causing it. You're going to see language problems as the dementia progresses, impaired abstract thinking. You're going to see poor judgment and reasoning. Like in the winter, I'm going to go out in a tank top and it's snowing outside. Or in the summer, we put 6 layers on. Difficulty with impulse control, poor coping skills, slower reaction times, loss of initiative, and loss of ADLs. And ADLs are activities of daily living. So that's dressing, bathing, eating. I want you to all envision you have just flown over to a country you have never been to before. And when you deplane and walk into that airport, you're unable to follow the signs. You try to ask someone for help, but they don't speak the same language. You know someone is supposed to be meeting you to give you a ride, but you don't know how to find baggage claim. You don't have a phone to call them. And as you look around and listen, you see others, you think everyone around you staring at you because you're a stranger and that they're whispering about you. So you hold your luggage close and try to determine what to do next. And that feeling you have from that is what someone with dementia, just a smidge of what they feel like every day, all day. And so I share that because I want people to have a little perspective of why someone's struggling so much and how we can give them a little grace and empathy as they go through this journey. One of the hardest things that caregivers face is communicating with someone with dementia as they go through the journey because their ability to communicate changes. So, what is communication? Well, there's three parts to it. There's the tone of your voice. It's about 38% of what someone interprets when they're talking. They listen to about 7% of what you're actually saying. But most importantly, 55%, they're following your body language. And what's so interesting about this, because I've seen it happen, I'll be in a room talking to someone and something will trigger on my phone or on my watch, and I'll go to look at it. And they go, "Oh, do you need to leave?" Because they're not listening to a word I'm saying. They're watching and how they're feeling around me and paying attention to my nonverbal cues. So it's really important we remember that when we're communicating with people. Steps for communication with dementia. So I want you to approach from the front and establish eye contact. Call the person by name and get down to their eye level. Let them initiate touch, but put out a cue. Because sometimes with sensory touch can be very startling to someone with dementia because their vision is very impaired, as I'm sure with anyone with a vision impairment, having someone come up behind you and touch you is very startling. And so we want to communicate every step we're doing and cue if anyone does have some vision that they can see your hand and they can make the initiative to touch. We want to give directions or state requests one at a time. And so I want you to think about this. If I told you all to go brush your teeth right now, how many steps that might take? If you think about it, it takes close to 35, depending on where you are in your home, because you have to, the directions just to get to that space to then get started on the complex task. So when you tell someone to brush their teeth, it's not as simple as it sounds. And so when you say that to someone with dementia, they can't process that, overwhelms them. And that either will lead to a breakdown where they're crying and upset, or they just go do something else. So very important that we do things very simple and give cues and give them support with that, such as let's walk into the bedroom. All right, now let's walk into the bathroom. We're going to turn the light on. We're going to get out the toothbrush, the toothpaste, the cup. Now we're going to turn on the faucet. We're going to fill the cup with water. Now we're going to put the cup down on the counter. And so we do all those pieces because they can follow smaller steps. I want you to speak slowly and clearly and simplify things. And I want you to allow time for them to respond and take action. So it's really important. You ask someone with dementia a question, you need to give them 90 seconds to answer. It takes a while for the brain to process to get it down to the lips for them to answer back. And sometimes the question's too complex. So if saying, "What do you want to have for lunch?" that's too much for them to think. You might need to say, "Do you want soup or sandwich?" And if that's too complex, I then want you to say, "Do you want a sandwich?" They can answer yes or no. Okay. And be aware of their nonverbal signals. They might not be able to tell you they're in pain, but they might be rubbing their knee, and that's a sign that something hurts. And so we need to really pay attention to those things as well. Some general communication tips as well as use a lower tone to reduce anxiety and encourage positive environment. That also plays a role in people who have hard time hearing. They have a better chance of hearing a lower tone versus a higher tone. We also want to create an environment that facilitates good communication. So that means turning off the TV and the radio and other things around us so they only hear you. Use a tone that reflects respect, being patient, using statements rather than open-ended questions. I want you to avoid idioms and metaphors and slang. And most importantly, Q-tip, quit taking things personally. A lot of times people with dementia don't have their filter anymore, as we call it. And they might say some things that are really inappropriate or it could be hurtful. It's not their fault, it's the disease. And so I want to make sure that we just let it roll off our shoulders. And that's easier said than done, I know, because we're humans. But let it go. You can process it in a support group with someone. You can talk to someone one-on-one about it. But it's not their fault, it's the disease. Some other things, try to understand and respond to the emotion behind the verbal and nonverbal signals. So an example for that is if someone says to you, "I want to talk to my mom," and their mom's been gone for quite a while, she passed away. We don't want to say to them, your mom passed away, because then they're going to relive that grief. So instead, we want to say, tell me about her. What was your favorite thing about her? Oh, she liked chocolate chip cookies. I love them too. Do you put walnuts in yours? And you're talking about that feeling of something important to them without talking about mom, because it's more about the feeling behind it. Or a lot of times they'll say, I want to go home, but they don't mean the home they just moved out of, maybe. They might mean the home from when they were a kid. So find out why home is special. Okay. Connect with the person's sense of self. So this is really important. So I want you to think of a tree trunk and all the outer rings that are there. When you have dementia, those outer rings start to go away. Those inner rings, the heartwood of the tree, that stays. And so if you can figure out what someone's heartwood is, you can connect with them. That's who they are. That's their essence of who they are. And so, I have someone I work with who a couple of years ago, she was speaking salad language. And I said, you're not going to believe what happened this week. And she's just looking at me. And I said, they overturned Roe v. Wade. And she went, what the hell are they going to do next? And it was the clearest sentence I had heard in 2 weeks from her, or 2 years from her. That's her heartwood. That's who she is. And so I know if I do anything around politics and women's rights, she can answer yes or no questions appropriately, even at the end stages of dementia, because that is her essence of who she is. Some other things to do to communicate: the long-term memory and the response to music are the last two things to go. And so reminiscing and doing activities that are in their long-term memory, you can get more engagement with, versus things that are new or different that they don't know how to do. And with music, it helps in so many different ways, from anxiety to stimulating memories to positive feelings. And so using that, I have someone who was just thanking me yesterday for a music box that we put a bunch of songs on. And her and her wife, her wife isn't engaging as much anymore, but when that music's on, they have that sense of peace because those are songs they relate to. And she'll start to open her eyes and tap her foot and hold her wife's hand. And that's magical. Music can do that. With some people, it gets them to talk in a full-blown conversations. Everyone reacts different to it. Important to use humor. I love using dad jokes all the time with people to make them laugh, because we all just need to laugh once in a while. There's too much going on in this world for us not to. And I want you to provide reassurance and love. They need to be seen and heard and known that we care. And so sometimes when they get frustrated with things because they're tired and they've had a long day, sometimes we just need to say, what do you need from me? Tell me more about what's going on, and just let them vent, even if it doesn't make sense at all, because they have mixed salad language, as we call it, and their words are garbled. They feel like they're being seen and heard, and they're letting those emotions out. And so it's really important to give them that floor to do that. Some common behavioral and psychological symptoms we might see with dementia are mood swings, uncharacteristic suspicion or jealousy, so that paranoia, hoarding, rummaging, and pacing, so walking back and forth, collecting things to keep, looking through drawers, socially inappropriate behavior, avoiding situations where failure occurs. So stopping going to church because you can't remember names or keep up with the conversations, being agitated and aggressive, having delusions and hallucinations, being repetitive. And that can be going up to someone and saying the same thing over and over again, or it could be hitting the counter over and over again, or rubbing something because of the texture. The last thing is sundowning. It's not my favorite term because it happens different times of the day. It's not necessarily when the sun goes down. What the definition behind that is someone who has dementia, their brain works 3 times harder than ours. And so you and I can get up and work for 12, 16 hours and still be functioning at a pretty high level, even though we're tired. Where someone with dementia, if they wake up at 6 in the morning, 8 hours later at 2 in the afternoon, they're done. Their brain is maxed out. They're exhausted. And so that's when we might start seeing the agitation and the aggression and the behaviors, because their brain and body is tired because they work so much harder to do things. So depending on when they wake up, find out where that 8-hour mark is. And that's probably where you're going to start seeing things. So can you give them at that point some music to listen to, or take a nap, or be in a quiet space so that they can let their brain rest? Really, really important. A person living with dementia is not deliberately trying to be difficult with you, I promise. These behavioral symptoms are a product of the disease that is affecting their brain. So it is not their fault. And I want you to look for the strengths, the things that they can do. We always say, if you don't use it, you'll lose it. And so sometimes it's faster for us to do things for them, but we want them to do as much as they can for as long as they can. And if it's in their long-term memory, like brushing their teeth, that is something that can stay a lot longer. They just may need cueing for it. And we want them to do it as long as they can. Okay. So some things that can trigger some of these behaviors are environmental triggers like noise. Hearing a siren from an ambulance can trigger it. Light being too bright or too dark, being overstimulated because they walk into a room and they're hearing bingo being called. There's TV on over in the other corner, and that's too much for them. There could be a physical need that causes this pain, hunger, and thirst can cause these behaviors. Psychological need, so loneliness and boredom and sadness. There's a sensory impairment and misinterpretation. Very, very important. We tell people this all the time, is that if you don't have your glasses on and have them cleaned and have your prescription up to date, or have your hearing aids in and have them charged or their batteries in them, or have the right hearing aids if your hearing's decline more, you are more prone to having your dementia decline faster because those sensory tools are impaired. If we look at a psychiatric illness, like the delirium I mentioned, that short-term dementia from an infection, depression can cause a cognitive impairment, having paranoia disorders, a change in your health status or your medications can cause this, a change in your routine. This is really important for someone who has a dementia diagnosis. Structure and routine is so important, but if we change that routine, we can see a cognitive decline. That's why we say, if you're going to move someone, because that changes their routine, make it the right move the first time, because if you keep moving them, that can make them decline faster and faster. And then the biggest one that can affect them is how we as family and staff and community approach someone. And so we want to make sure that we don't trigger things because of what we're doing to them. So it's really important that we're mindful of that. So your new role as someone helping someone with dementia is, I want you to know that when you meet one person with dementia, you've only met one person with dementia. No two people are alike. No one matches the definition in the book. There's no one size fits all to the solutions or the challenging situations that you may come across. Because here's the thing. Yes, they both have a diagnosis of Alzheimer's, but each person had a different life experience. And we don't know if one of those two people had trauma in their life. And as you go backwards in time, because that's what dementia does to you, your mind might get stuck at a teenager when you were abused. And so if anyone gets near you, you get reactive to that. And so that's why everyone's experience is different, because we don't know what traumas and life experiences someone had that could trigger things. So most importantly, with your new role, you have to put on a detective hat to figure out all these pieces. And it won't happen overnight. It's going to take time, and it will change periodically because the person changes with the disease. So what can you do to make these changes and make this journey purposeful? A lot of people, when they see dementia, they think, oh, life ends at that point. It doesn't. Life continues, and it can have positive moments. So as I said, the long-term memory is one of the last things to go. So I want you to reminisce with them. Get picture books of things you guys did with 1 or 2 words, so they don't have to say, who is this? But they can see that, oh, this was Hawaii in 1962. We went on vacation there. And that's going to trigger that conversation. I don't want you to argue with them. You're never going to win an argument. I'm going to tell you, after over 20 years, it doesn't happen. So don't try. Don't correct or criticize them. They can't fix things anymore, so don't try to correct them. And I tell people the best explanation for that is, we are always taught to be in that parent mode as we grow up, to teach and correct and fix problems. We can't be in the parent mode. We have to throw that to the wind. Okay. I want you to use simple explanations. And behavior is a form of communication. So I want you to consider the context of their life experience and their current situation they're in. And I need you to look for the emotions behind those behaviors and validate those emotions. So, for instance, someone's had a really long day and they're tired and they get agitated in the dining room, and she immediately says, "This person attacked me." In that moment, one, we need to get her to a quieter space, but we also need to acknowledge that she feels like she's been violated. And we need to say, "Would you like to write a report up?" That tells us we're listening, we hear and we see her, and we want her to be able to feel like she's being seen and heard. And that's a great way to do that. You want to talk to someone about it? Do you want to write a report on it? Whatever that might be, so that we can meet that need. So remember, the person with dementia cannot change his or her behavior. We have to change our response to their situation. So most importantly for you as a caregiver, our battery needs to be full to be able to take care of someone. Just like we're on a plane, they say if you're the person taking care of a child, who puts the oxygen mask first? The adult does. Okay. So as a caregiver, the things I want you to do for yourself, I want you to take care of your physical health. So that means getting out and exercising. And if it's standing in front of the TV, running in place while watching I Love Lucy, that works. Whatever works for you. I want you to manage high blood pressure. Make sure you're going to those doctor's appointments. You're taking that medication. You're eating healthier. Okay. 7 years running, the Mediterranean diet is the #1 diet for health. Being physically active, keeping your mind active. And that can be as simple as you go in and brush your teeth every night and use the opposite hand and stand on one foot. That is changing up your process and challenging your brain. Okay. Stay connected with your social activities. This is key. We found this through COVID. They were doing studies on it beforehand, but it became more evident that social isolation, and there's a study done by AARP, if you have prolonged social isolation, which happens with caregivers because they're taking care of their loved one, it is the equivalent of smoking 15 cigarettes a day. It tears down your body. Okay, so you need to be social, you need to be engaging with people and doing things. That also helps manage your stress. And this also will reduce your risks of cognitive decline. Okay, so these things are really, really important for you to do. You have to take care of yourself or you can't take care of them. And so that's why respite care is so important, whether that's someone coming for 50 minutes so you can take a walk outside, or if that means that someone takes care of your loved one for 2 days, will you go to a hotel and hang out and just give yourself a break? Okay. All right. So that is the end. We do have events on our calendar. You can go to insightmcc.org/events. We do lots of presentations, and a lot of them are virtual. We have support groups online that are virtual as well. All of our education classes are recorded, and you can listen to the webinars. So those are available to you. But I'm open for questions, and thank you for having me here and sharing this information.
Thank you, Melissa. I'm going to put the website and the phone number in the chat for everyone, and it will, of course, be in the YouTube description as well. If you have questions, please feel free to either drop them in the chat or to come off mute and ask.
I sort of have a question, but actually you helped answer a question for me, Ms. Long. My mother had just stopped responding sometimes, and I wasn't sure if she I didn't knew she wasn't being rude, but it was a new thing, and I guess now I know she's having trouble either processing or getting the words out. And so the 90-second thing, I think I'm going to be using that and be more patient.
And maybe too, you need the music to trigger. I had a woman, I was working at Fairfax Hospital, and she came in as a Jane Doe, and for some reason they think Melissa has magic powers, and so they sent me upstairs to see if I could figure out who she was. And I went on the assumption she might know Sunday school songs, and we got to about the 6th song, and all of a sudden I asked her who she was, and she remembered her name. So sometimes the music will stimulate that conversation as well. So you can always try something like that too.
Yeah. Okay. Thank you.
You're welcome. I know I gave a lot of information. What are some of the other classes we do? So we just did one on neurocognitive decline and how to prevent it. In February, we had a discussion on gun safety and dementia. I never thought that'd be a conversation I would have, but I had multiple families come to me because we're an open carry state in Virginia, and they didn't know what to do with these family heirlooms and having someone with dementia in the house. So we had a great discussion on that. I had someone in January talk about early onset and how to get Social Security disability, because that's a big question when someone isn't eligible for normal Social Security with all the dementias. Are you eligible for a certain Social Security? And so we had that discussion. We're going to have a speech therapist talk this upcoming month about eating and how that changes with dementia. We're going to have chefs for seniors the next month, and they're going to talk about nutrition. So a bunch of different things. You can always sign up for our education newsletter, and it comes out every Monday in your inbox, and it tells you all the classes coming up. So you're more than welcome to do that. But we've had lawyers talk and financial advisors. So I've done some presentations on engagement and doing activities. So there's all sorts of different things on there. And I try to do new and different things. I have the frontotemporal lobe group speak and the Lewy Body Association speak on different topics as well. Every June, we do a presentation for the LGBTQ community as well. So, just trying to bring different things to the table. If you guys ever have any ideas, let me know. I love hearing other people's ideas of things they want to hear too. Are your support groups available online and open to us in Maryland? Absolutely. I have people in California and Connecticut participating in my support groups. That was one of the blessings from COVID. We do over 25 support groups. So I want to say at least 12 to 15 of them are online. And so you are more than welcome to sign up for those and participate. And you can go on the support group page, and it explains what each one of them are. So, and you can see the times to figure out if that works for you. Some are in the evening and some are during the day. Thank you, Ashley, for all your help.
My pleasure. My pleasure. So, I actually have a question.
Yeah.
In my line of work, I have met and gotten to know and care for patrons and those who are aging.
Mm-hmm.
And I guess my big question is someone who is tangentially service or care to those who may develop memory issues as they age. What are some ways that me as a professional or can support the caregiver?
Yeah. So a couple of things. I think providing resources is really big for them. Also, just listening and saying, I have an ear. If you just need to talk. And I tell people on a personal level, if you know someone going through this, if you're at the grocery store, call them and say, hey, what do I need to pick up for you? And I'm going to come drop it off. Because having little simple things like that done for you takes so much weight off your shoulders as a caregiver. Or picking up Starbucks and going over and saying, I'm going to sit with Jim, you go for a walk, here's a coffee. And just giving them a break. Doing those things, or just showing up and mowing their lawn, not even asking. So doing those little things can make such an impact when you've got so much on your plate. And they don't know how to ask for help. They don't want to burden somebody. They don't want to ask for help. And so if we can do that, and as a professional, giving them the resources, but also, saying to them, what can I do? What can I help with? Do I need to get more resources for you? Or do you want me to call and get, sign you up for the support group with Insight, and then it will go right to your email? I can do that for you, taking away that step. Because sometimes it just, that list gets longer and longer. I mean, when I train people to get dementia certified with professionals, I actually have them make a list of what they think the caregiver does. And my favorite one is when I say, if you all don't pick this one, you cannot be my caregiver. And I would say maybe 10% of the time they get it, but they forget about pet care. And I'm like, my dogs are important to me, so you better take care of my dogs. And so, you know, they just don't think about all the other pieces that are tied in with it. There's a lot to do as a caregiver. So
I know a few of us are on here that serve communities,
mhm.
you know, through public service, through libraries and things like that. Some individuals are in here and they serve their information hubs for their individual communities. Could you, I know I put it in the chat, but could you once again give us your website and your phone number?
Yeah. So it's www.insight, so INSIGHTMCC.org. And then the phone number is 703-204-4664. And so that will allow you to have access. We have so many resources. And I think one of the important tools I can give you, because I'm sure some people are thinking, well, if I have impaired vision, how do I take a memory screening where you have to draw things and look at things? There's actually a version for people with vision impairment. It's through the MOCA, the Montreal Cognitive Assessment. So if you're ever worried about yourself or someone else with the visual impairment, we can still do a cognitive screening without drawing and moving things and touching and seeing things. So please do know that that is available. And I've actually quite a few people, I do quite a few memory screenings in the community. And I've used that before. So
I had a question.
yes.
Are your services free or is there a charge for people to take advantage of what you offer?
The only thing we charge for is our day center, and that's down in Virginia. So anything for you guys online, you're good to go. Free, we get grants, fingers crossed we keep getting them, as everyone says, but in private donations. So yeah, it's free to you guys to utilize any of that stuff.
And would you have resources for people who provide local services in the Maryland area, or would you can you suggest where one can look to find those?
So the best place for you is to look in your county's AAA, so the Agency on Aging, for each of your counties. And they're going to have an in-depth list. I know PG County has an actual caregiver handbook that they give through the AAA. Yes, the testing is free, to answer that question that just popped up. And that's something I could possibly arrange with Ashley, that we could set up doing some assigned screenings and do something like that, even though I'm far away, since we don't have to do the written part. So I'd be happy to do something like that, and we can make it just for you guys. I'd be cool with that. So, but yeah, your AAAs are your best bet. I don't mind researching and looking, and I do know more the southern end of Maryland. And I'm happy to help with that. So you can always reach out to me. But yes, your AAA is your best resource.
As far as dementia resources here in Maryland, if that's a need, I'd be more than happy to put together a list and share it out on my various networks.
Yeah.
And I can coordinate that with Melissa, so she can, if I miss a few, she can, you know, offer some. So if that's something people would like, you know, just email me. I'll put my email in the chat and I'll make that happen.
Yeah, that's great.
All right, we're down to our last few minutes. And, you know, I want to be respectful of everybody's time. If you have any additional questions, please feel free to reach out to me. This is Ashley from the Library for the Blind and Print Disabled. I can be reached at ashley.biggs, BIGGS, 1 at maryland.gov. And I can be reached by phone at 410-230-2430. And I'd say if everyone can come off mute and give Melissa a huge hand for this wonderful presentation, I would appreciate it. So, yay!
Yay, thank
Yay.
you.
Thank
Thank
Appreciate
you
it.
so much.
Thank you.
All right, ladies and gentlemen, thank you so much for being here. I will be sending out the link to my various networks of the recording, and you know, I will include a couple of resources here in Maryland to get things started for you. Again, thank you everyone for being here, and looking forward to our next LBPD Live. We do have some events, so go to our website. You know, we've got a lot of stuff going on. Thanks so much. Have a great night.
Thank you.
Thank you.